Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Hello, this is Pam Arlotto, and welcome to the Eye of the Needle podcast. Today, I have a long-term friend, industry visionary, and observer, Mark Hagland. He is editor-in-chief of Healthcare Innovation magazine. Interestingly, a few years ago, the magazine was called Healthcare Informatics, and Mark and his team had the vision to know where we were going as an industry, and they completely revamped their brand. Mark talks to a lot of people, he interviews, he writes, he holds summits, and he does a lot of thinking about the trends in healthcare. Mark, can you tell us a little bit more about your background and how you ended up where you are today?
Certainly, Pam, and it's a pleasure and it's an honor to be invited by you onto this podcast. So thank you so much, first of all.
Thank you.
We've known each other many years. As I like to say, when we were both in the womb, we met.
Yes, we were babies.
That's right. I have been in healthcare publishing for 36 years now. A lot has happened. I know you know that. Let me start actually with the name change for our publication. Healthcare Informatics was an esteemed brand, and it had been in existence for many years, actually, long before I joined. I became a senior contributing editor in 2000. I was brought in on staff in January 2010. So I basically have a 25-year relationship with the publication. We've seen a lot of changes in the industry. And we did decide 6 years ago to change our name to Healthcare Innovation. We were already covering a lot of things that went way beyond the informatics title. And that was actually kind of cramping our style. People were like, well, your name is Healthcare Informatics, but you're writing about accountable care, and clinically integrated networks. And we had to constantly explain. So it was a good name change. We really cover a very broad range of issues, from federal healthcare policy all the way through every operational issue in hospitals, large medical groups, and health systems, to core health IT issues, to cybersecurity. So there's a lot. There's a lot there. And what I will say is, you and I have talked about this particular subject many times. I think it's an exciting time in healthcare. Of course, it's a scary time. Anyone who would say it's not a scary time is deluded. But it's also an exciting time because many of the things that were envisioned 20, 25 years ago are finally actually happening now. We're actually doing value-based contracting now. We're actually implementing early stage artificial intelligence now. And we're starting to revision the healthcare system, which I know is what you and I want to talk about in depth today. So it's very exciting. Honestly, for me, it's a great privilege to be sitting in the position where I am. And I talk every day to people who are a billion times smarter than me. And that's why I'm able to share interesting thoughts with you.
That's perfect. And so we're going to take a little bit of a different format than I often do with my guest. So we're going to spend the first half of this, and I'm going to ask you questions. And because you're the interviewer extraordinaire and you've talked to so many people, then the second half, you'll ask me questions, and we'll see how that works out. But I'm sure we will have a very interesting conversation. So let's start off with the major trends that you believe will truly transform healthcare that you're observing today?
Well, I would start with the burning platform. What is the burning platform? Well, I always like to share what happens every year in June, which is that the Medicare actuaries, who I'm sure do a lot of other things, project total annual U.S. healthcare expenditures for the next about 8-9 years.
Right.
We are currently at about $4.6 trillion in total annual U.S. healthcare expenditures, more or less a couple 100 billion. And the actuaries told us in June, we are going to 7.7 trillion a year.
Wow.
My goodness, I was never great at math, which is why I had to go into journalism, but I can add and subtract, and 4.6 to 7.7 trillion in 8 years, there's your burning platform.
Absolutely.
And yeah, and fundamentally, we are aging. I'm aging faster than anyone else. Uh, we have an aging population and this explosion in chronic illness. So what's happening now is we are seeing, and unfortunately, we're seeing chronic illness in children at a level we never saw. Some of it is obesity related, and there are other factors as well. So what the healthcare system has to do now is shift over to primarily caring for and care managing individuals living with chronic disease. That is going to be the bulk of our expense. We'll always have, unfortunately, we'll always have car accidents, things like that. We'll always have people, having heart attacks and strokes. Of course, that will happen. But the vast bulk of our expenditures will be around chronic illness. So the burning platform is very clear, and the purchasers and payers of healthcare, meaning the federal government, state governments, and private insurers, are saying, basta, enough. We cannot have this incredible level of rising cost every year. I have a good friend, a good personal friend, who is the CEO of a vendor company that manufactures those kiosks that you
Mm-hmm.
use when
Mm-hmm.
you go into the doctor's office. She has about 150, 200 employees, and last year she called me, and I wasn't really able to help her, but she said, my health insurance has just gone up 125% this year compared to last year. So a very big, very burning platform. And what the payers and purchasers of healthcare are saying is, you providers have to figure this out. We cannot be like, my friend, we cannot be paying 125% more next year than this year in health insurance. And as you know, because you've been in the industry a long time, it's all complexity. There's no single reason why things cost so much. And our healthcare system is just almost surreally complex. But what's happening now, so I'm going to flip this to a slight glass half full view, which is what had been predicted for many, many, many years is happening. And that is, we are looking under the hood of this auto that we call healthcare. And we are finally going to the core of care delivery, care management. Some of it is clinical, some of it is clinician workflow, some of it is operational issues that can be fixed. Why is hospital care so tremendously expensive? I mean, the people who work in hospitals are the most dedicated people in the world, and they love their patients, they love their communities. They're in this because they care. But hospitals still are tremendously inefficient places.
Right.
And the people in C-suites in hospitals will quietly admit that. They won't necessarily say it on the record for publications, but they will admit, if they're sitting down, with you over coffee, yes, we could
Right.
be a lot more effective. So that's where we have to go. And one of the key things that is happening that is really, really accelerating now is the move into accountable care organizations, clinically integrated networks, narrow networks, payer provider partnerships, the whole range of things. That's the most exciting thing to me, because when you combine looking at core clinical operational issues and trying to improve those, along with really trying to improve care management and population health management, and these new payment forms and models, I think that's where we get change.
So I know you mentioned when you made the decision to go from healthcare informatics to healthcare innovation, you've mentioned to me that you found yourself having different audiences, both for your publications as well as your summits. In the past, it might have been a CIO or a CMIO or an informatics leader, but more and more and more, you were finding it was the C-suite, across the board. And what are you seeing that those individuals that you taught with, that read the publications, that participate in the summits, what are they looking for, and what roles are you seeing that may be new to the table in some of these areas?
Yeah. Well, collectively, the healthcare system is like a damsel in distress looking for a prince who will save her. But realistically, the most leading edge organizations have individual leaders within them, and I know you've met many of them, who are transformational in their thinking.
Right.
They're saying we just can't do the same old thing over and over and over and over and over for the next 50 years because A, we'll go bankrupt, and B, we'll lose all our jobs. It's going to be very bad. So the C-suite leaders are saying a couple of things. First of all, they realize at a high level that what they do has to change. A fundamental thing here is the inpatient hospital will always exist, and we know that, but it's going to be smaller. And it's already becoming a semi ICU, right?
Fair. Yes.
Yeah.
Yes.
And some of this is driven by insurance mandates, right? Like the insurers want you out of the hospital as soon as possible. And now we have hospital at home, which is starting to blossom. Every single hospital at home program is completely different, which is wild. But the leaders in the industry are saying this is where we have to go. And we have the information technology, the medical technology, and the general technology to be able now to do hospital at home. So over time, the inpatient sector is going to shrink. And the inpatient hospital will always be there, but it will be one nodule in a big web of services. And the real leaders, the transformational leaders in this industry are saying, we have to look to a time when the proportion of inpatient to outpatient will flip much more even towards outpatient. And we have to look at the continuum care as an actual constellation. People have talked about it for years, but they've really still been super inpatient centric,
Getting
right?
those heads in beds, right?
That's right, heads and beds, right? And one of the challenges right now that we cover a lot on the publication is the organizations that are moving ahead most clearly and most successfully with accountable care are the large medical groups. And that's because the large medical groups that are not parts of health systems, they don't have to put heads in beds, right? And
Right.
so many of them are moving into contracting that is kind of pseudo capitated or getting, it's a mix, but
They're
it's
taking on some risk.
they're
Yeah.
taking on risk.
Yeah. Yeah.
They're
Yeah.
taking
Yeah.
on two-sided risk. And they can do it because, again, they're not weighted down by the necessity to keep their inpatient hospital 90% filled or 85% filled or whatever. The challenge for hospital leaders and health system leaders is they have to think future minded. They have to think about when they flip over to the bulk of their revenues coming from outpatient. And it's a hard thing to do because, if you grew up if you came up through the ranks in an inpatient environment, that is your mindset, right? That's your mentality. And, you could never have expected the leaders of the buggy whip industry, to say, yeah, we're going to focus on electric cars, in 1890, right?
Right.
They were still focused on producing buggy whips. And so we're in that strange liminal space where people can kind of see the future, but many, frankly, are not ready. And you and I have talked about this a lot, and I know we'll talk about it today, that there is a kind of entropy
Mm-hmm.
that
Mm-hmm.
exists in many hospital organizations with super smart people, but they're just doing over and over what they've been paid to do, right?
Forever. Right. It's
Forever.
based on the old model versus
Yeah,
this future vision you're describing. Right.
yeah, yeah. And at every hospital retreat, they have a speaker saying, this is the future and blah, blah, blah. And then everyone applauds and they go home and they do, they do the same thing, right? So
Over
we
and
need,
over.
yeah, we need to get past
Well,
that clearly.
so much of what you've talked about is not the technology being kind of the center of the universe, but the technology enabling some of this great change. And,
Yeah.
we've spent the last 20 plus years implementing and optimizing our electronic health records. And
Yeah.
one of my theories is that some organizations are kind of stuck in that optimization world where they're still trying to make the workflows work based on the way they've always worked, as
Yeah.
opposed to thinking through some of these new and creative technologies like ambient listening, or
Yeah.
where's AI going to take us, or even remote patient monitoring, or on and on and on and on. There's so many new opportunities, and they're not envisioning what we could be. So, I mean, what where do you think the industry is on that? I mean, is the bulk still stuck, or do we have some flag wavers out there forging these new paths and driving us to this future?
Well, I think so. I'm going to do a glass half empty, glass half full thing here.
Fair. That's
So
fair.
first, yeah, so first the glass half empty. I would say, and this is a complete guess, and I'm totally open to your perspective on this. My guess is probably 2/3 of hospital leaders are still kind of in the past or the present, which is soon to be past,
Yes.
right? About
Yes.
a third, I mean, we can debate the exact proportion, but about a third are like, okay, yeah, we actually have to give up what we've assumed was the truth.
What got us here won't get us there in the future.
That's it. That's
Yeah.
it exactly, Pam. And so those people, one of the things, AI is so interesting because it's interesting in and of itself. It's fascinating. I'm like spending half my time writing about AI, but it's also interesting in that it gives us the possibility of revisioning the future and making a real leap. You said something a moment ago that was absolutely right. We had to implement EHRs. I mean, we just had to. In the year 2000, only like 20% of physicians said EHRs. I mean, we
Right.
had to get out of that,
We've
obviously.
come a long way since then, for sure. Yeah.
Yeah, we've come a long way, and we could not have done it on paper.
Right.
So all the things that we're trying to do with population health, et cetera, that is going to be turbocharged by AI. AI can do things that, think about what it would have been like, or what it was like, let's say in 1995, for nurses to look at any particular clinical outcome, like readmission of within 30 days of CHF patients. They would have been sitting with piles and piles and piles of paper, quietly, writing in pencil or whatever. That kind of work that would have taken 2 months can be done literally in minutes now.
Yeah. Sometimes
Like
seconds.
seconds, sometimes seconds.
Exactly.
Right? Yeah.
Exactly.
And so there's a huge potential there. The other thing that I think is going to really be transformative is, and we're just at the very beginning steps of this, and that is clinician workflow. The single thing that is irreducible is the time of physicians and nurses. You cannot substitute the time of a physician with the patient or a nurse with the patient with anything else, right?
Right.
You can have the most efficient housekeeping service of any hospital in the country, and it won't make a big difference if your nurses and physicians are overwhelmed and they can't fly, right?
Right. Right.
And AI is going to help us with that. That's one of the biggest things it's going to do. As we start to free up that time, they will then be able to work up to the highest clinical levels possible. And then we will be able to kind of transform patient flow as well. And that's one of the things we have to do, because the other great crisis, besides the fundamental financial crisis that we're facing, is the staffing crisis. As you know, a whole bunch of nurses quit during
During
the
COVID.
pandemic. Yeah.
Right. Right.
And the healthcare system has relied since forever on a certain verity that the typical nurse got their RN degree, started practicing maybe around the age 23, 25, whatever, and then worked until they were like 65. we just had a huge break where younger nurses
Right.
in practice a shorter time left. And within 10 years, all the studies are saying we're going to have a real crisis with nurses.
Yes.
So one of the things that we have to do, and this isn't even so much future-ish, this is present-ish. We have to figure out how to optimize the time of our nurses. If we can't do that, we're really sunk.
I
So
agree.
so the glass half full part of this is there is a real opportunity to actually transform care delivery. And that is what is going to move us forward. Um, I had an experience years ago that has never left me. It was a very brief experience, but I was working on my first book, which about 3 people read. And I was invited to a Toyota plant in
Mm,
Georgetown, Kentucky, outside Lexington. And people always ask me, oh, was it interesting? And yes, it was fun to ride around on those vehicles and see people soldering. But the single thing that I carried away from that experience was in all of these auto manufacturing plants, they have big whiteboards where anyone in the plant can suggest anything
right.
for
Right.
improvement. And of course, they constantly have meetings. They're following Toyota production system or lean or whatever. And the thing that just struck me and has stayed with me ever since then, and that was about 18 years ago now, was everything is questioned. And
Mm-hmm.
that's our opportunity to question, to say, why are we doing this way? And it's hard. It's easy to say, let's question things, but it's hard to do it because there is just this stasis where in healthcare is a very conservative industry in the sense of it just keeps doing what it's always done.
And compliance driven. And there's a lot of
Yes,
rules that make you
yes,
do it the same way every time. And
that's right.
so people kind of get check the box as opposed to
Right.
critically thinking, can we do this differently? Is that fair
Yeah.
perspective?
That's yeah, we're in a rut.
Yeah.
We're,
Okay.
to
It's a
put,
good way to say it. We're just in a
right.
rut.
Use complex technical terminology, we're in a rut.
Yeah.
So one of the things that you and I have talked about a lot is we need visionary leaders who are going to say, I'm not just going to think about the next 6 months, which they still
Right.
have to think about. I'm going to think about what are we going to be like in 2035? Like what does that look like? And it's not going to look the same as it did before. And also the healthcare consumer revolution is finally here. And one of the things that happened during the pandemic was people realized they were consumers of healthcare. And there was that terrible time at the beginning of the pandemic where we were all basically kind of stuck in our homes to an extent. And people went wild and they ordered things online, like from Amazon. And I'll never forget, I ordered a pair of running shoes. And they not only were the shoes perfect, they came in a box, the whole thing. It was set up so that there was a return receipt if they didn't fit or I didn't like them, I could immediately just put them in the box, take it to FedEx. You know, they wrapped it up and they sent it free of charge. And I remember thinking, wow, healthcare isn't like that, right?
We
And
still aren't.
we still aren't,
Yeah.
exactly. And so healthcare consumerism is now finally arriving, and the younger patients they're saying this is not acceptable. You know, sitting in a waiting room for 2 hours is not acceptable.
Mm-mm.
You know, uh, getting a prescription refill, having it messed up 3 times and having to call 10 people 10 times to get it fixed, that's not acceptable. So healthcare also is going to have to go through not only its information age revolution, but also this patient experience revolution.
And service mindset, because you're right.
Yes,
We're still often facility centric and or provider centric.
very.
And it is so complicated and so
Yeah,
it's confusing to us, and we're in the
yeah,
industry, much less an
yeah,
elderly person who
yeah.
doesn't have a caregiver. And I mean, it can be very difficult to
Very
navigate.
difficult. Very
Yes.
difficult.
Yeah.
Absolutely.
So from your perspective and all these, I'll call them visionaries and change leaders that you talk with, what are they most concerned about in terms of, because you're talking about there are people out there who have the vision, but then there's a big chunk that just aren't there yet. What are these people who do have it? What are they concerned about the chunk that doesn't have it? I mean, what's your take on that?
Well, what I'll tell you that everyone is concerned about is financial survival. The difference is that the visionary leaders understand that to survive and hopefully to thrive, they
Mm-hmm.
can't just do the same thing. And that's where the big divide is, right? There are a lot of, unfortunately, there are a lot of senior C-suite leaders in hospital systems in this country who are still committed to doing the same old thing the same way. And they don't, the thing that they don't realize is that everything is churning at the same time. I mean, look at what just happened with this bill that passed through Congress and was signed by the president. We're going to lose $1 trillion in Medicaid reimbursement. And there will be upwards of 8 or 9 million just losing Medicaid. And then some people will lose their insurance from the marketplaces because of increased rates. So one of the things that healthcare leaders have to do is they have to rethink. Okay, imagine you're a children's hospital or a children's health system. And I've been talking to some wonderful leaders from children's health systems. You have to make a double leap. First, you have to think about what you're going to be in the future, fewer inpatient hospitals, fewer filled beds, much more being taken care of outpatient, hospital at home, all that, care management, all these things, and with less reimbursement.
Right, right.
And that's hard. I mean, I only have to write about this stuff. I don't have to do it. So I think the leaders in the healthcare system are realizing they have to walk through this fire of the next several years, and they cannot be fear-based, right? I think one of the things that is, honestly, we don't really talk about it, but it's keeping people in stasis, is fear of making change, because you can do it poorly, right? Like
Right.
you can,
Well, I kind of call it that there's a fear of the unknown and fear of uncertainty. And so there's this tendency to just be paralyzed and wait
yes,
until all the answers come. Well, I think
yes,
you and I both know there's been so much uncertainty for the last 20 plus years, and it's only getting more uncertain.
yeah,
Those that wait will suffer and may
that's
not
right.
survive.
That's
You've got
right.
to act. You've got to put a plan in place, look at what's in your control, and go. I mean, is
Yeah.
that fair from your perspective?
Yeah, that's exactly it, Pam. And the organizations I admire and the leaders I admire, they lift up a banner, a flag, and they say, this is our banner. It's going to be transformation. It's going to be the patient truly at the center. It's going to be the technology of the new world. It's all these different things. And they do it, right? There's so much debate right now within AI about, should you wait or should you grab a technology that is still developing? Well, the answer is really, you have to grab a technology that's developing. If you wait 10 years, you'll never catch up, right?
I tell my clients, this is a time to learn about it.
Yeah,
And you may not end up using this. It's not like implementing an EHR. You may not use this system 10 years from now or this AI, but at least you'll begin to speak the language and understand how it works and understand how it's different and how it impacts your workforce. But if you wait, you'll never catch up. I mean,
right. And AI is fascinating because it's a tool, or it's a set of tools. You have to learn how to work with tools, right? This is
mm-hmm, mm-hmm,
and the early, one of the great things about the early leader organizations in AI, and I've interviewed many already, they're not afraid, right? Or
right,
at least their courage outstrips whatever fears they have. They're going ahead. They're saying, look, let's fail fast, right? That is, we often talk about failing fast in healthcare. In AI, more than anywhere else, fail fast. You learn from your early mistakes, and then you move forward.
right.
And it's impossible. It's like learning a foreign language. I love foreign languages.
There you go.
Thank you. I inevitably end up referencing language learning, but it is very much like that because there are people who will say, "Well, I couldn't possibly learn a language. I would be so embarrassed to make a mistake in front of people," right? Well, then you never get anywhere.
Right.
And I've learned the most from my mistakes and the languages I've studied, the vocabulary that and grammar that is most seared into my mind is when I've made embarrassing mistakes.
But you won't make it again.
You won't make it again. You're correct. And that's exactly what the leaders are doing in AI. They're making mistakes. They're making mistakes, but they're making mistakes intelligently, if that makes sense, right? They're saying, okay, we're going to try this. We're going to try blah, 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 and we're going to see what this is. It's piloting, right? It's the
Right.
basis of all piloting. And then they quickly say, rather than it being like a 10-year project, it's 3 months, and they say, oh, this was a whoops. Okay, we did this one thing, and we realized, we angered the nurses, or whatever happened, and then they quickly correct it, and that learning is the basis of the next learning. So I think in a way, what's happening in AI is an analogy that we can think of for the whole healthcare system, right?
That's
We're going to
great.
have to fail fast, learn quickly, learn from our mistakes. Obviously not fail and then just stay failed, right? That's not an option. But the leaders are courageous, and they're also willing to do something really important, which is they're willing to think outside the box and do outside the box, and not we can't be so focused on, like, well, our CFO has always had this assistant named Susie, and she has these very strange idiosyncrasies, but we just have to take care of Susie, right? There's way too much individualized thinking in a certain way.
Mhm.
I mean, we have to honor individuals, but we also have to say, how do we turbocharge this so we go from 2025 to thriving in 2035? And that requires a willingness to smash some things in a good way.
Well, and I bet if you looked over the stories that you've heard from all the people you've talked to in the past year or so, that there would be a pattern amongst them. And part of it is this willing to take risk,
Yeah.
willing to do things differently. I mean, are there some
Yeah.
others that just kind of that you think people really need to pay more attention to?
Yeah, I think, well, I mean, the first thing that they need to do, they, we talk about this all the time. We talk about employee surveys, and I think from what I've heard, the way that they've executed these employee surveys is just honestly kind of lame. It's, do you feel listened to, yes or no, right? We they have to, hospitals and health systems have to get much deeper, right?
Right.
They have to figure out, how do you create an environment in which everyone feels invested in taking good risks on behalf of the organization to move it forward? Because then you have an army of change leaders. One of the things that you and I have talked about a lot in the past is how an organization will hire someone, and as we've discussed, one of the hot titles is Chief Transformation Officer.
Right. Right.
They'll hire someone and they'll say, okay, now Linda is our Chief Transformation Officer. We're not giving her any staff. We're not giving her any budget. We're not giving her any vision.
But go forth and transform, Linda.
right. We're giving her a box of pencils, and she's
Right.
right. And this is where I think they're making a lot of mistakes, because the organizations that are doing that, because you can't hire a chief transformation officer who is now going to sit in a little office and write little
Well,
reports.
and you see the same pattern over head of patient engagement or population health.
Yeah.
Or I mean, we could just go on and on and on, all the new titles, but what's the impact of what they're really accomplishing? Right.
Yeah. Well, and because many of those organizations honestly are kind of follower organizations, so they hear that the hospital down the road has a chief transformation officer or a chief patient experience officer, and they're like, oh, well, we need one too. So it's the equivalent of buying technology, right? They have a certain technology, we have to buy it too. And that's where the lack of strategic thinking plays out. And in fact, as you and I have talked about, doing that in a very limited way can actually end up backfiring and putting you back as an organization, because then you hire the chief transformation officer. Like I said, I'll just call her Linda. You hire Linda, and then she fails, and it's not Linda's fault. It's
No.
the organization's fault. They gave her no resources, they gave her no vision, they gave her no staff, they gave her nothing. And then they expected her to transform. Well, that just it doesn't work that way. So if you're going to hire these new titles, you have to put something behind them. And above all, you have to have C-suite support and endorsement for what they're going to do, because otherwise they are going to fail. You
Yes.
can't do this and expect good results unless, and that's where the top people in the C-suite, you and I have discussed this, there's some who are going to have to retire, right? And obviously no names in this entire healthcare system, but
Right.
I was asked to speak at a retreat a few years ago, and of course, no identification at all of the organization.
Right.
And it was very, very well intentioned, and the presentations were good. But I will tell you, it was clear to me, absolutely clear, that this organization is one that's just going to do the same thing the same way over and over. So they engage speakers like myself to talk about transformation, but I had such a strong sense that they're not going to do it.
Well, they'll probably have the same speakers next year and do
Yes.
it again and again and
Yeah.
again.
Yeah.
So let's flip the question.
Sure.
Why don't you ask me a few?
Well, one of the things, and Pam, I just admire you so much. You're a real leader in the industry, right?
Thank you.
And I'm not just saying that to butter you up, although if you that's fine too. But one of the reasons I admire you so much is that you have always thought outside the box. And let's talk a little bit about years ago, we did a piece together, and it was CXOs 2.0. And now we need to move into higher point O's. When you look right now, what is your glass half empty, glass half full sense of this? Are we going to get the people we need who are going to move us forward? Because as you know, healthcare, as I've said, healthcare is very process conservative. Most CIOs, the earlier CIOs, were data managers, right?
Right.
And they just suddenly got promoted, or as I like to say, the CEO called up Joe from the basement and said, "Joe, you're the CIO." And the Joe was like, "Oh, that's so nice. What's a CIO?" Right? We just have to not do that.
Well, and I think from my perspective, most health system leaders, they went and got their MHA, or they've come up through the clinical route or whatever, and they were taught to operate, not to innovate or transform.
Yeah.
They almost have to go learn those skills and those tools, because those are different, whether that be through finding an innovation partner like a local incubator or accelerator, or bringing in a strategic advisor who can help on getting you to think about how your culture needs to be open to experimentation and to learning. We've talked about the learning health system forever, but are we really, really driving that kind of change? And I think from my perspective, we've gone through this period of, building out all these massive enterprise technologies. And now it's time to trouble spot and to look at our relationships with our patients and our consumers and look outward, not just inward. And I think those leaders that do that will be several steps ahead than those that are still in okay, I have to run this nursing unit, or I have to run this financial office,
Right.
the traditional sense.
Yeah. And let me give you one example and have you opine on this.
Okay.
One of the roles that I find most fascinating, partly because I've interacted with them the most, and also because of the very curious way the role has developed, is CMIO. chief
Oh,
medical.
I can go on that one for a
Yeah,
while.
good. I want you to, because as you know, the first CMIOs were kind of tech head doctors, right? And the organization was about to implement their first CHR. And they said, oh, let's call Dr. Smith. He likes tech. Obviously, we went way beyond that. But what is fascinating to me now, and I want your view of this, is the true CMIOs, the true CMIO leaders are way beyond that now. They're really thinking about how do we marry optimal clinical technology, clinical information technology, with where our entire clinician cadre has to go. You know, physicians are burned out, you know, all the things we know. How do we get way over here? And I think that one of the things that's happened is the earliest CMIOs just kind of dropped out. They dropped back to being in practice or whatever they were doing, because it's no longer just about choosing an EHR. Obviously, we had to go through that phase. Now it's about revisioning how clinicians work. Your thoughts?
Well, I was just out at AMDIS in Ojai, which is the CMIO professional meeting. And we teach a little course at the beginning of that for new CMIOs or individuals who want to take their career to the next level. So we've thought a lot about this. And one of the biggest changes I see is this newer generation of informatics leaders. They don't want to just work under IT and be responsible for optimizing the EHRs. You see them getting into population health, into analytics, into quality and care delivery redesign. A number of them are working with companies and they want to be entrepreneurial and innovators. I've met physicians there who never actually start practicing medicine, but immediately start building a company that's going to solve the problems they saw in residency. I think the opportunity, these guys are systems thinkers. They think more broadly about change. They're not just the doc cheerleader or the doc police around using the EHR. They're really about how can we reinvent the way we care for our patients. And I told them, I spoke on a panel on uncertainty, and I said, guys, think about your own personal Venn diagram. You've been exposed to different things that will make you an expert. So one guy came up and said, prior authorization is when one of my circles. I've done a lot of work in that. And I'm like, well, you're the informaticist that knows that. Another guy was all in reinventing access and patient engagement. Who knows better than a clinician of how that can work differently? So they need new tools like design thinking and jobs to be done and some of the methodologies around agile that they weren't taught in medical school. But once you arm those leaders with that, they're unstoppable. And they don't want to be put in a box of optimization or only working on the EHR. And so what they have to do is find partners either in operations or in innovation or in population health that want their expertise. And so I think there's a huge opportunity. Unfortunately, I'm hearing about some of those roles that are being eliminated or disbanded because they're still tied from senior leadership's perspective to EHR. And they're like, we spent enough money on the EHR, we got to spend it on some other things. So that's my take on that.
I agree absolutely. And I think one of the reasons I mentioned CMIO is because it's such a fulcrum point role, right? And these are people who understand informatics, understand information technology, but also are clinicians. To go back to my Toyota plant story, you can find new ways to clean the shop floor that are better than ever, but that's around the edges of what
Right.
what a car
It's
plant
not
does.
going, it may not make the car better. Maybe it'll make
Right,
everybody who's working there feel better, but
right,
right,
exactly.
right.
Now where we are in healthcare is we're finally at the point where we're lifting up the hood, we're looking at the engine, we're looking at the parts, and we're saying, was this car built correctly? We have to start asking these more fundamental questions. We've done everything possible with group purchasing. We've had 30 years of really
Right.
good purchasing work. If we get 0.01% cost reduction beyond what we've done, that'll be about what we'll get. But when you start looking at how the patient flows through the inpatient hospital or through the clinic or whatever, it's amazing how much fertile ground there is there.
Yes.
But what you said about CMIOs is exactly right. We have to empower them. And
Yes.
what is your sense of, in different organizations, how best do we empower the actual people who will be our change agents?
Well, one of the things I'm seeing, and I think there's an upside and a downside to this, is we're beginning to see a lot of these new innovative, transformative, disruptive approaches coming from outside IT. You might have an operational leader who they use their iPhone, they use technology in their personal life day in and day out. Why can't they deploy and lead a new initiative? And I think what we're going to find is, rather than worrying about the traditional hierarchical reporting
Yeah,
relationship, it's going to be building collaborative, multidisciplinary teams where a number of skill sets and competencies
yeah,
and capabilities come together. And so those change agents that have the power, have the budget, have the leadership strengths will go find those team members that also can contribute in a big way, and teach individuals who may be more junior how they can also lead. So I mean, that's part of the reason for this podcast. I call it the eye of the needle, because we've got so many problems to solve and so many innovative companies, ideas, and leaders, but getting them together is like going through an eye of the needle. It's very difficult. And so that, I think, is going to be, they need to find each other and work together to lead their organization versus the traditional, you report to me and let's go make it happen.
exactly, Pam. And I think, and I'm pretty sure you'll agree with me on this, one of the core problems we've had in healthcare, especially in hospital organizations, is this unbelievable balkanization and of fiefdoms, right?
The
And it's like
silos.
the silos, the people silos, not just the process silos.
Right.
It goes back to medieval guilds, right? Like I love reading in world history, especially European history. And if you read about the medieval guilds, they were fascinating, but they were very, very jealous people, jealous of their territory, right? If the bricklayers got onto doing something that the ornamenters guild was doing, there would be this war. And this is how hospitals often work in practice, right? One person will say, well, why don't we do such and such? But then three people will recoil and say, well, that might impact my little guild, my little fief, my little territory. And that's one of the hardest things to break down. And I think what you just said is exactly right, Pam. The transformative leaders are going to have to find each other, like almost like their secret society initially, find each other and say, oh, you match me. We want
Right.
change. We don't want to. Here's the thing, we can't just be improving processes that aren't taking us anywhere, right?
Well, that's why I say we've struggled so with value-based care and population health management, because we hung it on the old fee-for-service chassis.
Yeah,
We didn't design a new operating and business model that would work in that environment. And I believe that's what we're really going to have to ultimately do
yeah.
as it becomes more prevalent.
Yeah, I absolutely agree. Wow, we're finding it difficult to find anything that we disagree on.
Or talk about.
Or talk about, right. No, I think that's exactly right. And of course, I love that you furthered the car building analogy. But I think that's exactly right. I've written a lot about the MSSP, the Medicare Shared Savings Program. It is still the largest government-run program for ACOs.
Right.
They've had a lot of successes, but it is a little bit hung on an old chassis. And
Right.
the interesting thing is the greatest level of innovation right now is coming on the private payer side, because they have so much flexibility. They don't have to do like a proposed rule and do the rulemaking through Congress and all that, or through the agency. And the private payers are figuring out we've already had a couple so far, and next week we'll be in San Diego, and I'll be on a panel with a payer provider collaborative in Southern California that's just done wonderful things. because they came together. They said, what is the problem? And one of the key problems was serving the Medicaid population called Medi-Cal in California. It was totally disjointed
Right.
just because it evolved that way, right? No one said, I'm
Right.
going to create a disjointed system. And
Right.
they realized that it was all scattered and kind of smushed up. And so people in the health plan on the medical management side came together with this very large network of clinics, some of them FQHCs, and they mapped out process. This is a classic thing, right? Where do we lose Mrs. Smith, right?
Right.
What,
Right. Right.
simple things like Mrs. Smith didn't get her prescription filled. Why not? She didn't have transportation. There wasn't good enough communication. There wasn't follow-up from the nurses. Mrs. Smith was referred to a specialist. What happened? The specialist's staff didn't make it a priority, and there was a long way. Like all these things. And what's fascinating is it all ends up being human processes. But there's flexibility on the private payer side that the government side doesn't have. And that's where some of the most interesting innovations are happening. They're happening in accountable care organizations that are private payer based, and they're happening actually in Medicare Advantage.
Well, and I'll tell you, one of the biggest, I think, impacts that kind of hurt some of the MSSP programs is, even though they attributed patients to a practice, and that primary care doc was kind of supposed to manage their care, et cetera. The one thing you'll find in medical practice, they're not going to treat patients differently based on who their payer is. They're going to
Yeah.
treat everybody the same. And if only a small percentage of their patients were getting under a value-based care contract, they may or may not do the types of things that would
Yeah.
make that care, if they're still primarily in a fee-for-service mindset. And so I think what you see often is when they get a volume enough of patients or members to be able to do something kind of and kind of turn the incentives on their heads and look at how can we truly use common sense and use some of these tools and technologies and use the data to help us learn about these patients. Having a big enough patient population or patient portfolio, if you will, makes a huge difference. If it's just, less than 10% of your patients, you're going to treat everybody the same, and that would be fee for service. So I think that will have a big impact too, where we see more and more and more like Medicare Advantage coming under these type of models.
Yeah. One great example in Arizona is Banner Aetna.
Yes.
Aetna came together with Banner Health, and they said, look, we're going to do this. And there are enough physicians, it's a few thousand physicians, that it's changed care
Right.
delivery. That's the other thing. We have to get to scale on some of these innovations.
Oh, thank
You and I
you.
talked right, yeah. I mean, if you have 3 docs working with 200 patients, you're just, you might improve the life of one Mrs. Smith, but you're not going to change the healthcare system at that rate.
So I advise this healthcare, or actually they're multiple industry, but they innovate and they build new companies. And their founder wrote this book. Can you see it? The Illusion of Innovation. And he talks about big companies doing innovation theater. And I think healthcare does that all the time. We name something, or we have a pilot, or we buy a tool, but we don't really change anything. And
Yeah.
one of my beliefs is that, and some of the CMIOs fall into this, but others do too. We've gotten really good at managing change, but we're not yet good at committing to change. We'll send out all the notices and get people in for training, but are we really committing to doing something different? And I think our new group of leaders, our new change agents, our innovators, our transformers, our disruptors have to make that commitment and get their culture to commit not just to doing a pilot or doing a little, naming Linda as VP of whatever.
Yeah,
So
right, exactly. And what's funny is, and I'm sure you'll agree, many of these little pilots are very successful, but they're at such a small scale
they
that they
don't plan to scale them at all. And you should plan to
right,
scale before you ever start the pilot. If you can't
right,
do that, you
because
shouldn't even start.
yeah, otherwise it's just this cute thing you did,
Yeah,
right?
cute. That's a good word for it.
Yeah. It's so cute. We did this one little thing for 2 months, and we changed one process, and now we've forgotten about it, right?
Yeah. Yeah, exactly. Exactly. All right.
I would just say, Pam, what is your advice for the people in organizations who want to be real change agents, who don't just want to lead one tiny cute little pilot, but who want to get to scale? How are they going to have to navigate what is so often a culture of stasis? That's
Mm-hmm.
my issue, right?
Mm-hmm.
How do they navigate that and break through so that they can build a system of change rather than, as you pointed out, the theater of innovation?
So I think you have to truly look at your organization. I did a review and it looks like somewhere between 150 and 200 health systems have some type of innovation initiative today. And those didn't all start out with a bang and, and investing lots of money or whatever in their innovations. I've got one CHIO I know, and I did a podcast with him where the innovation hubs in his area together to help him. He's testing and trying new things. He's hired a couple of staff. That's within his control. And depending on the organization, you're not going to right turn the culture overnight. So starting small, getting success, and in those areas where you can make a difference. Sometimes it might be partnering with somebody in operations or somebody across the table in finance if you're a clinician. I think there are a lot of opportunities, but people feel kind of like, well, my organization will never do it. They kind of give up. And
Mhm.
sometimes it's just finding where can you have influence and really helping those around you understand, because sometimes they're not always going to read your mind. And
Yeah,
so start where, go to where you can have the biggest impact.
right. And that all speaks to what I just said a moment ago, which is breaking out of the culture of stasis, right?
Right, right, right.
Yeah, absolutely. Well, wonderful, Pam. If you and I could just run all of healthcare,
We
things
just
would
like
change.
talking about it now.
That's right. That's right. No, it's been such a pleasure to speak with you, and I think we're in a Vulcan mind meld here, honestly.
Well, I think there are probably a few other people out there too who think like
Yeah,
this. So, well,
yeah,
thanks so much, Mark. And it's been
yeah.
great having you as a guest today. And thank you for interviewing me as
Oh
well.
yes, absolutely. I love the back and forth of it, and thank you. It's been an honor to be included here, and I just want to thank you for being a true change agent in the healthcare system. We need about 3,000 more people like you.
Or 5,000 more people.
Or 5,000. Yes, exactly. Exactly. One in every organization. But I will just end by making this comment, which I made at the very beginning of our conversation. It's a scary time in healthcare, but it's also an exciting time because I think people in general, whether or not they're actualizing any of this is a different question, but they realize to a large extent we cannot just keep doing the same things the same way. And as I mentioned, we're going from 4.6 trillion a year in annual US healthcare expenditures to 7.7 trillion. I mean, it really is mind-blowing. And as I like to say at our summits, we have 8 summits this year, and I say this at the beginning of each one: if your mind isn't blown by those figures, you don't have a mind, right?
Right. And it's at a time when our population's aging and things are just getting more and more uncertain and complex. So
They are. And the CMS actuaries said we're going to go over 21% of GDP,
wow.
which means more than 1/5 of all the dollars that are spent on anything cars, toys, houses. 1/5 is going to be spent on healthcare. And healthcare policy people will debate whether that's a bad thing or not, but I will just note that no other country is even close to that.
Right.
The closest to that is about 16% in Switzerland. And most of the European nations are more at 11 or 12%. So 21% is just, it's mind blowing. Anyway, we'll have to get
Thanks
that.
again. And
Thank you.
we'll talk soon.
Yes. Thank you. And have a great day, everyone.
You too.